So welcome to this next edition of Video Denver Underground. I'm Spencer Tomberg. I'm an emergency medicine and sports medicine physician. We're going to talk about scaphoid fractures today. So welcome. We are going to talk about the scaphoid. And the scaphoid is a bone of the wrist, one of the carpal bones. And there's lots of different injuries that can happen to the wrist. But in emergency medicine, we tend to focus on the scaphoid more because of the high risk these injuries have for losing blood supply to the bone. And if you get avascular necrosis after an injury, there's a chance that you can get early onset arthritis, or that you can have collapse of the wrist after an injury, 5-10 years down the road, that causes patients a lot of problems. So the scaphoid itself is a carpal bone that's on the radial side. It actually sits on the border of the carpal tunnel on the radial side right there, and it's also at the base of the thumb. So that's going to drive a lot of the ways that we examine it and the ways that we look on it, both on x-rays and clinically as well. So breaking your scaphoid sucks. The treatment for it is long-term casting. When we're talking long-term, we're not talking like 6 weeks. If proximal fractures get splinted for up to 5 months, 6 months sometimes, fractures at the waist 3 to 4 months. So this is a long time healing process, and you should set your patients up for that. Some surgeons are actually going in and fixing them early, and they find that if hardware is put into place, sometimes they can get people kind of up and moving out of their cast in about 2 months. So getting somebody to a hand surgeon for further evaluation is important one way or the other for these fractures. All right, so let's talk blood supply for a second, and we'll see this a little on the illustration here too. But there is an artery that comes from the volar aspect, that's the side with the palm, and it goes to the top of the scaphoid, and that part actually gets really good blood supply. On the back of the scaphoid, the blood supply comes up, and it goes into the middle of the scaphoid, right at the waist, and then comes back down. So the blood actually comes from the distal end and comes back proximally. That part of the scaphoid is very susceptible to avascular necrosis. The rates of it, depending on how far you go down, can range anywhere from 50-60%. If it's at the very distal end, even 100% of these fractures can get avascular necrosis if they're not stabilized right. So because these fractures are so high risk, they make really good test questions, but those test questions aren't always clinically great. So the first thing to talk about is the anatomic snuff box, which you can see right here. And we're taught to palpate in that area. And if there's any pain in there, then we immobilize people, regardless if their x-rays are positive or negative for a fracture, because these fractures can be small and they can hide, and we can only actually see them sometimes based off the healing process we see in repeat x-rays. Now, there's a problem with this, and that's that a branch of the radial nerve actually travels through there. And if you try it on yourself, if you push into your snuff box hard, it hurts. And because it hurts, it means that we end up immobilizing a lot of people that probably don't need to be immobilized. And there's better ways that we can examine the hand and the scaphoid for a fracture. So the other problem with the snuff box is to see it on people. We usually have them bring their hand into radial deviation. And when we do that, if you feel down the finger here, this is the base of the thumb, the metacarpal, it goes all the way down to there. If you can feel any carpal bones there, that's probably your trapezium. The scaphoid is hiding really deep in there. So let's look at an illustration that shows this a little better. So to start with, this is just a hand overlying kind of the vegetative illustration of where the scaphoid is. And if we actually look at the scaphoid in the normal kind of anatomic alignment, it's pretty deep in there. Now you see, if you put the hand into radial deviation, the scaphoid gets much deeper in there, and you could barely touch it on an exam if you were trying really hard. If you look at the x-rays in normal anatomic alignment, the scaphoid, you can only just get to that distal end. So when they get the scaphoid view, they actually put the patient into that ulnar deviation, really to open up the space so that you can further evaluate it radiographically. The way to get actually access to the scaphoid itself is to put somebody in ulnar deviation. Then you can bring the base of the thumb to here, trapezium, and if you still go deep right there, that's where the scaphoid actually is. So to fully evaluate them, you have to bring them into ulnar deviation to even get access to the scaphoid at all. Okay, so better ways to examine the scaphoid. So if we think about the location of the scaphoid, one thing we can do is we can put direct pressure down on the thumb, which is called axial loading. And when we do that, the pressure gets transmitted through the phalanges, down through the metacarpal, through the trapezium and into the scaphoid. So that's one way we know that there could be a scaphoid fracture if there's pain with axial loading. The second thing that we're going to look at is that the scaphoid's actually on the radial side of the carpal tunnel, which you can feel right in your wrist there. So if you're concerned about a scaphoid fracture, you can palpate that area on the side of the carpal tunnel. And if there's pain there, that's probably a better indicator that there could be a fracture of the scaphoid. And that patient would need to be immobilized until they could have either repeat x-rays if their first x-rays didn't show a fracture, or if you do see the fracture, then you immobilize them and get them in to see a hand surgeon. All right, so now we know somebody has a fracture, and what do? We're going to get them to a hand surgeon. That's going to be our next step, but we need to immobilize them. And the best way to immobilize them is with a custom splint and a thumb spica splint. There's been some studies that looked at just immobilizing the wrist. They're probably not ready for prime time to not do a full thumb spica. So we're going to do something that's plaster or fiberglass that's going to mobilize the wrist, short arm. We probably don't need to take the elbow out at this point. We're moving over towards Velcro splints for other small fractures, but because of the risk involved with this fracture, we should have them either in fiberglass or plaster, really to lock down the wrist so we're not getting any movement from it. And that kind of wraps up our discussion of what to do with scaphoid fractures. Thanks for watching.